So it is 3:03. We will start, and while introducing today's webinar, people will be connecting in. So welcome everybody to this ninth webinar of the Quality and Safety Network. It's been already almost 2 years, full 2 years that we've been organizing these webinars, and we hope you do enjoy the quality of those webinars. Just a quick reminder for those who join us for the first time. The purpose of this network is to share best practices and experiences all across Europe, because it has been one of the most effective ways just to get to know how others work and how we can learn from others to improve our own health systems, and maybe more about quality of care and patient safety issues that are one of our priorities. So, as I said, we've been organizing these webinars since 2019. You can see here all the topics we've already covered since then. If you're interested in one of these webinars, they're recorded and available on our YouTube channel, and I'll be chatting in the link if you're interested. And this 2021, we already had a Portuguese patient safety culture assessment. That was the last webinar. And today we'll have a focus on an Estonian experience. And we'll be ending the year with a patient-reported incident measure webinar hosted by PACS, which is a Belgian study about how patients can report their patient safety issues. So here we have the date, 14 December, and you'll be able to join and to register to this webinar also. So today, there is a lot of people registered for this webinar, a lot of people from all across Europe, so that's interesting. The webinar is recorded, so it will also be available for others of your colleagues. So without further ado, I will leave the floor to Teel Orgse. She will tell us about how quality management is something that can help improve patient safety. So Teel, the floor is yours.
Thank you. I will start sharing my screen. I'm very delighted to be here. And yeah, it was very interesting to listen to all the previous ones that you've mentioned, and kind of made me jealous in some points. But on the other hand, there can be different approaches. I'm not saying one is good, but this is how we in Estonian hospitals have managed with this patient safety topic. So just a small picture of Estonia. We like to present ourselves as Earth people. This is where we are in Estonia. And this is our flag, which looks exactly like the forest in winter. It's blue, black, and white. Just a short, this is an Estonian, but I just wanted to show you, this is the system of our healthcare. And, you know, it starts with the ministry and the Estonian Health Insurance Fund, and then other ministerial agencies that regulate what we do. But what about quality policy? Do we have one? Do we have a vision about quality and patient safety? And the honest answer is that our only real vision of Estonian quality, healthcare quality, comes from 1998, which was a document created with the help of the Dutch government. And then we have a ministerial decree on quality management or quality assurance, which actually dates, it shows 2004 here, but it actually dates back to 2002. There were minor changes. And now there is the National Health Plan that says this qualité and patiëntveiligheid mean quality and patient safety here in the right, I'll show you, in the right side of the on the picture. So it's just part of the National Health Plan, but there is no action plan actually about it. So what do we do in hospitals then? We have the Estonian Hospital Association that is a member of HOPE as well. There are 3 regional hospitals, 4 central hospitals, 11 general hospitals, and 6 other type of hospitals that are members of the Estonian Hospital Association. And from 2006, we formed quite a kind of a quality managers group within the Estonian health, within the Estonian Hospital Association with the Estonian Health Insurance Fund. And we're not doing this quality group anymore with the Estonian Health Insurance Fund, but in 2006, it came into life because we tried to join, or we did join the WHO PATH project, which was the quality indicators project. But after that, we have grown, and we've gone to separate ways with the health insurance fund. But we have monthly meetings among the quality managers. And what we have done, we have unified our patient satisfaction surveys. So we do that every year together, and we compare and we develop them. We have also developed together as a collaboration patient information materials. We have started with complications and adverse events reporting systems together. We also share and support each other in building our quality management systems. Some hospitals have patient boards. And this year we did the hospital survey on patient safety culture together. I'll come back to that later. And we also piloted the OECD patient experience survey on patient safety. Just a few words about Estonia, because we tend to be proud of it. Internationally, locally, there's another thing about it, but we as quality managers have a lot of work to do with the Estonia. And here on the left side, you can see some really huge national projects that have affected us all, and we have to work with it. So we have e-invoicing since 2001. We don't have any paper on invoicing anymore. We have a national digital electronic record since 2008. So all patient records are, online. And the same goes with prescription. The national digital prescription system from 2009. And then it evolves. So we have national e-consultations in between doctors at the moment from primary care to specialist care, but from this year on, in between specialties as well. And we have national e-ambulance since 2016 and national digital booking system since 2019. So patients can choose where they will go to a doctor, and they do that through the digital booking system. So, and quality managers have a lot to do with that, and we actually do have to work a lot to make that workable. So what about hospital quality management? And here I will actually this is what I will go into detail about, but I will show you a study that we did this year. And it started with our health board director giving an interview. He is not a health board director anymore since last month, but he said that he thinks that Estonian hospitals don't have quality management systems. So we reacted to that and conducted a study. But I also wanted to show you about primary healthcare. So this is the Estonian Health Insurance Fund logo, and they have since I think 2004 already started to develop primary healthcare quality system, and they established it in 2006. And so all the primary care doctors get to be part of like this quality system where they have to report how they are doing with like chronic illnesses and patient management, etc. And then they can also get this kind of quality award or quality mark that they put out in their practices. So there are some national initiatives. So what I'm going to present now is a study about quality management in Estonian central and regional hospitals. So that's 7 hospitals. And I will try to show you that if we don't have like a national top up rules or vision how to improve quality or guard patient safety, then we can do it from bottom up. So what we did, we first searched what kind of quality management aspects are there, and we took a JCI standard, which is an American standard about hospital quality management. We took the Estonian ministerial decree, and we searched literature, and we formed interview questions. So we have 76 questions that we asked from those hospitals. And I did the first part of it, and then the second part was tested by another quality manager, and we improved the questionnaire. And then I conducted 6 interviews. The 7th is my own, which were all 2 hours long, with hospital quality managers. And here are the hospitals mentioned that participated. So we attacked 8 quality aspects with those 76 questions. One was about leadership. There were 10 questions there. Patient safety culture, 3 questions. Patient safety management, quality management, customer service, patient centeredness, personnel management, and other quality management aspects. And here are the results. So first, for vision and quality strategy and leadership. So all hospitals have a leadership strategy, and all hospitals have a quality management system. And in addition to that, all hospitals have also a documentation system or a manual. This is actually that comes from ISO standards, for example. And it also comes from our ministerial decree that a quality management book has to be there, but it's not a book in itself. It's actually a documentation system or a manual. All hospitals have some sort of quality strategy. Some have their quality strategy inside their leadership strategy, but all have it nonetheless. And 3 hospitals have a specifically defined patient safety in those quality strategies. Leadership role in ensuring quality is defined by 4 hospitals. And quality improvement system is specifically defined in 1 hospital. One has a need-based quality improvement system, and others have it as a middle manager responsibility. To measurement and reporting. All hospitals have a regular reporting system, and 3 hospitals have business intelligence system implemented. All hospitals have also a crisis management system implemented, which also goes into measurement and reporting. So, for example, if there is some crisis, or not necessarily like COVID pandemic crisis, but for example, some bacteria, for example, starts to rise, then through reporting system that can be managed. Also, all hospitals have internal audit implemented, including peer review and a clinical audit. All hospitals have also health record-based inspection, which means that we inspect regularly our patient health records and come and collect indicators from there. And all hospitals have implemented complication reporting. And to a different degree, also patient safety incident and adverse event reporting. It is very bottom up. There is no national regulation about how patient safety incidents should be reported. Nobody collects them nationally, so we do it from hospitals ourselves. Now, patient safety culture, this is very new. This is as new as 1 week. But this is an e-poster. It's in Estonian, but together with these central and regional hospitals, we conducted the Agency for Healthcare Research and Quality, which is in the States. It's a hospital survey on patient safety. And we organized it, we validated it into Estonian language. It was led by the East Tallinn Central Hospital. And then we conducted it this summer and collected data this September and presented it actually last week with this poster. And the results are something that we still have to analyze a lot. But what we can see here is that quality improvement, which it's in Estonian here, but anyways, the quality improvement part is what our hospital personnel regarded as highest. So 71% say that quality improvement exists in our hospitals. The lowest result was with work like hours and how much work personnel have to do. And it's, of course, getting worse during our COVID pandemic here. But the rest of the results are around 65, 60, 63%, which shows that around 2/3 of our hospital staff are quite satisfied with the patient safety culture in Estonia. So all the improvement work that we now have to do based from this study will also come from within the hospitals. So from back to the original study that we conducted, then 5 hospitals have declared blame-free culture. 4 hospitals have regular quality case discussions, and 3 have need-based quality case discussions. This means patient cases where some kind of quality problem was detected. So 4 of those hospitals, actively seek them out, 3 do them when they arise. About patient safety education, so we actually don't have any national patient safety education platform. We have at our Tartu University, which is our only medical faculty, we have 1 medical faculty. So they have a patient safety center now, but it's a collaboration project with the Spanish and Dutch institutions, and they are still in the kind of science phase and education phase within the project. So it has not had any national impact in that sense that there would have come like a national patient safety education system or anything like that. So we as hospitals do it ourselves at the moment, but that might change pretty soon. We're waiting for news. So out of those 7 hospitals that we studied, 4 have trained their staff on patient safety with different schoolings. One hospital has defined its never events as they're not defined nationally, and 2 hospitals have defined its always events also, which I think is very good. And all hospitals have implemented patient identification procedures, and all of those hospitals have also special wristbands for inpatients and also emergency patients. So that is not a national requirement either. Now to patient safety management. So all hospitals have special infection control services, including special procedures implemented for prevention and hospital infection reporting and also analyzing. And this is actually very well done, and it started up as bottom up as well, decades ago already, coming from the university again, where the infectious diseases professor kind of started this bottom-up approach, and it's I think very strong, and I don't think we have any problems with that in Estonia that we would need to address specifically, but it also has a special law about it. So even though we don't have this national patient safety vision or strategy, we still have different laws that affect hospitals, and that is one example. Of course, all hospitals have implemented hand hygiene procedures, and all hospitals have implemented medication safety basic procedures like administration, handling, and also decision support. AI-based decision support. So this also comes from law, as there are very specific regulations about medication safety. But there is a lot to do in medication safety still. And at the moment, all hospitals are kind of struggling because we just don't have the resources to take it to the next level. For example, I think there was a nice PUCS presentation about that over a year ago or something. So we're not there, but all hospitals are doing it as they can. So we don't have a clinical pharmacist's education. I'm not absolutely truthful right now because it actually did start last year, but they are all still learning. But the clinical pharmacists that we have, and one that is the longest is already, I think, 16 years. They have gained their education from Ireland and UK, and one from Cyprus or Malta or somewhere from there, from those universities. So they have studied themselves enthusiastically, and they have also formed a hospital pharmacists association where they spread the information amongst themselves. And but we don't have that many, so 4 hospitals have, and are very lucky to have them. 5 hospitals have declared and do offer second victim crisis counseling for their doctors and nurses, etc., who have been involved in some kind of patient safety incident. Another very difficult subject is patient restraint, meaning aggressive patients or delirious patients, or also psychiatric patients. Now, we only have law for psychiatric patients about patient restraint, but of course, those who work in hospitals know that it is necessary in other areas as well. So we have tried to navigate in the law so that we would be lawful, but patient safety would be, sustained, and for other patients and for that patient who has been restrained as well. So that has been a bottom-up approach as well. A very interesting thing that I would be very interested to learn more about from different countries is inpatient checkout, so to say. So how do we ensure that patients who check out from hospitals know what to do? Everything is done, that there wouldn't be unnecessary rehospitalization, et cetera, and that patient safety would be secured also at home. And 2 hospitals have developed a process for that. And other 5 hospitals that we studied have some kind of different procedures, but have not developed a whole process for that. All hospitals have a standardized practice for patient transfer and handoffs. And what was interesting for me from the patient safety culture study, for example, is that our personnel or our hospital staff really don't see it as a problem at all, compared to, for example, literature where patient transfer and handoffs can be a real patient safety issue. So there might be some extra education needed there. But at the moment, all hospitals declare that they have standardized it. 4 hospitals have implemented root cause analysis for patient safety incidents, and others do root cause by need. So if there is a need to do root cause analysis, they do it, but they don't do it regularly. Another example from different laws is transfusion control, which I also think is very well regulated by law, and thus all hospitals have transfusion control services, and all hospitals regularly have to analyze transfusion reactions. That really shows how if you implement a law, that it really puts forward some kind of procedures that maybe otherwise wouldn't be there. 2 hospitals have special systems for medication adverse effect analyzing, and others have it implemented in the general patient safety incident analysis. And that I really think comes back to the point that I talked about clinical pharmacists and kind of the lack of resources that we need for medication safety topic in general. So quality management. I really think that different quality management aspects can do a lot to ensure patient safety. And here are some topics that we picked out. Process procedures, which basically are like flowchart and guidelines and regulatory documents. All hospitals have on different topics over either all hospital-based or unit-based process procedures. Even though there are, European guidelines and national clinical guidelines, and etc., all hospitals have those clinical guidelines kind of implemented to that specific hospital, which means that also flowcharts and education programs to those hospitals. So all hospitals do it, how many resources they have. And as well, specific nursing guidelines. Now there's a mistake on my slide, but it says all patients, but it meant all hospitals. All hospitals have a standardized procedures and forms for asking patient consent, and it actually comes back because we don't have any patient law. We don't have patient rights, for example, this kind of law, but we have a law on contracts. And that comes back to the beginning of the 2000s. I think it was like 2002 or 4, or something like that. And the law about contracts, one of those I think it was chapter 41 or whatever, talks about a contract between healthcare service provider and patient. So basically our patient rights are declared in that law. And when it came into effect, it gave patients those kind of rights that actually frightened hospitals. In order to kind of back ourselves, we started forming those kind of patient consent forms. And there are different ways how hospitals go about it. Some have one unified form asking for all kinds of rights from patients, and others have patient consent forms on many topics, all different. All hospitals have implemented some kind of checklists on a different topic. Of course, the most famous one is the operation or surgery checklist. It came quite late. It came in 2014, actually. But there are other hospital checklists implemented as well. And then specific topics. 4 hospitals have implemented special thrombosis prevention systems, also checklists used there. All hospitals have implemented special bed sores prevention systems, and all hospitals have implemented special fall prevention systems. And 6 hospitals have implemented special pain management systems. Then there are special quality management systems, and that is also required by regulatory acts. So all hospitals have special laboratory quality management systems. Out of those 7 hospitals, all are also accredited, but it doesn't. It's not by law. You're not required to be accredited by an accreditation organization. But out of those 7 biggest hospitals that we studied, all have it. Then when we go back to radiology, then only 4 hospitals have a special radiology quality management system, but all hospitals do have implemented a special radiation safety prevention procedures. And there is also a special law about that. All hospitals have special pathology quality management systems. So there are 4 hospitals out of those 7 that actually have a pathology unit. So 4 out of 4 have. Back to those diagnostic procedures like lab and radiology and pathology, then 3 hospitals have implemented critical result response system. Meaning if the diagnostic department or specialists find a critical result, it is straight away communicated. All hospitals have regular clinical conferences to its doctors and other healthcare personnel. 4 hospitals out of those 7 have regular radiology clinician conferences, and others have them need-based. And kind of back to transfusion, then all hospitals have special blood product handoff procedures. This is also very regulated. One place to definitely have to, that we haven't developed, for example, I don't think any of us would could pass the JCI standard, but about medical technology utilization, then 2 hospitals have a special system for that, but others have certain procedures in the area. Customer service. This also comes from the ministerial decree So this is something that in the beginning of the 2000s was considered to be very important, that they didn't, I think they did define patient-centeredness, but it was talked about through customer service. So we all have to have customer service procedures available, and we do. And there are different approaches, and we're trying all to find our, our own right way to do it. As I said before, we all have regular patient satisfaction surveys. There is a movement inside the Estonian Health Insurance Fund that tries to have ambulatory services ask electronically patient satisfaction right away, but we have not yet agreed to that, but one hospital is already piloting it. All hospitals have special patient feedback systems, including complaints, and 3 hospitals use root cause analysis in that system. All hospitals have declared in this customer service procedure how they regulate patient, family member, and friend communication. There is a lot of work to be done in that area. I think it's also very culture-based. Inside Europe, I think we could have very different expectations, like what is the norm. Of course, COVID has made everyone crazy in that sense, but we have tried to regulate that as well, so that patients, family members could be involved, but doctors, for example, don't have to choose who they talk with. And all hospitals have implemented waiting lists, and they manage the waiting lists electronically. It's also required with our health insurance fund. Patient-centeredness. All of the hospitals have patient rights and responsibilities declared, and they're all publicly available, either on websites, or they have to be seen physically also in all of the hospital wards and ambulatory settings. All hospitals have addressed in one form or another patient privacy assurance. 4 hospitals have had special projects for patient involvement, but it is definitely something that we can work on more. And 2 hospitals have addressed the issue with certain trainings, like they introduce a new service or something, then they address how patients should be involved as well. Very new thing is this patient boards. They are not mandatory at all, and it's very new. A lot of our specialists have been, for example, through HOPE exchange program in, like, for example, the Netherlands or UK, and have seen those patient boards working there, and we've copied those things a little bit in the beginning, but those patient boards are now kind of forming their idea, like what is their role. And actually it was just 2 weeks ago that all of the patient boards, which is not only those 3 hospitals, because those 3 hospitals that I have mentioned here are from this study, but there are 2 other hospitals that were not involved in this study, but that do have patient boards. They met electronically 2 weeks ago, those 5 patient boards, specifically to address the issues about what do we do now? How can we be of service or what can we demand or whatever? So they have started their own kind of network. I didn't know how to say that in English, so I don't know how it will come out now, but all hospitals have topic-based patient information systems. And in that, I mean those patient information leaflets and materials and these kind of things that teach patients how to, be with your condition or how to take drugs, etc., etc. So we have all those hospitals have worked them out themselves, but inside the Estonian Hospital Association, we have agreed to share. If one hospital has worked this out, we can ask the other hospital and share our knowledge amongst each other. And the patient leaflets are also available on the Estonian Hospital Association website. And this also comes from law, as we're very Estonia, very digital, then this data protection is very important and it's mandatory. It's a ISKA standard now, so we all have personal data protection systems. And of course, other topics as well. 6 hospitals have regular personnel satisfaction surveys. 1 hospital said that they do it when the need arises. All hospitals have hospital-based continuous education training system. All hospitals have some kind of readiness for supervision. It's very bottom up. So doctors and nurses have started to demand it from hospital leadership, and all have done something about it. So 2 hospitals actually offer it very freely, and other offer it need-based or unit-based or special project-based. Of course, all hospitals provide occupational health services for its personnel. And we all have special infrastructure and supporting services, regulation procedures inside our whole quality management. And 1 hospital actually has a certified environment quality system. Here are some pictures, which is also very bottom up. We did the patient safety day. Pärnu Hospital, where I am from, did it for 2nd year, and University Clinic also for our 2nd year. We colored our buildings orange, and actually this year, Pärnu Hospital, where I'm from, colored our Pärnu, which is the city, theater, which is exactly in the center of the town. Everybody basically has to drive by it. And actually the leader of Pärnu Theater is the leader of our patient board. So it was a very nice thing. This is a picture of the biggest birthing center in Estonia. It's in West Tallinn Central Hospital. And that actually also came from our quality group, so to say. I would like to end, I can't remember anymore, but it's one of the books, like a book about patient safety, and there's the authors give like an introduction in the beginning of books to whom this book is, and the book is actually in English, but I couldn't find it for this presentation, and I had it translated into Estonian for another presentation, and now I translate it back into English, so it's not a direct quote. But I absolutely loved it, and this is kind of the vision that I am trying to spread in Estonia, for example, about patient safety in the hospitals, is that we do it to all the mothers and fathers who have lost their child because of treatment error, to all the husbands and wives who have lost their spouse, and to all those who have lost their belief in us, to notice our privilege that comes with the right to take care of those you love. So I think this is the message that we need to spread, that it is a privilege to care, to care of people who are loved by others. And I would like to end this bottom-up approach with a quote from JFK. I think this is the Estonian way of doing things, is we're not waiting for our country or our government to tell us how to do things. We are trying to do it ourselves, and as best as we can. And thank you.
Thank you very much for this presentation. It was very thorough. It's really nice to see actually how you mean a bottom-up approach can really look alike with a lot of national programs that are put into place by ministries and health institutions. So that's really interesting to see. And there were some slides where I was just asking myself, okay, what is there more about it? I would like to know about it. So you could do a presentation about every single point you've talked about. So that's really interesting. Thank you for sharing all that work. There were 2 questions in the chat, so I will give them to you. There was one you addressed, so maybe it was just repeating something, but about the patient safety culture assessment you organized late in September. Somebody asked about what questionnaire you used, and was it internationally recognized or Estonian? So maybe you can just repeat that part.
Yeah, so it was the Agency for Healthcare Research and Quality, the American government institution that has the questionnaire. It's called SOPS, Survey on Patient Safety for Hospitals. And they have other questionnaires as well. And we validated it into Estonian. We didn't validate it into Russian, but we translated into Russian as well. But we validated it into Estonian, yeah.
Yes. To add a little more information, in Belgium, we also use the same questionnaire. It has been validated in a lot of languages because it is an internationally recognized survey for measuring patient safety culture in healthcare institutions. And just so you know, they have hospital questionnaires, but they also have questionnaires for primary care, nursing homes. They have a lot of varieties of questionnaires to assess patient safety culture in different settings. So that was one question. Thank you for answering it again. And then there was another question about, well, firstly, thanking you for your great presentation. And then as quality and patient safety good practices are spread across the country, her question is, do you have a quality and patient safety champion among the hospitals?
Mm-hmm. Yeah, thank you for that question. I couldn't say so. I think that on different topics, it's a different champion. And I would also say that as it is very bottom up, we may not even know in some topics, the real champion who is doing something extraordinary in their unit. I remember we have this Estonian Hospital Association conference every year in September. And it is organized so that every year one hospital organizes it. So on the first day, there's like the national topics, and on the second day, there is like the hospital topics that the hospital wants to show to other hospitals. And last year, I listened to, for example, our children's hospital, Tallinn Children's Hospital. And I was just so amazed what amazing things they have done. And I had never heard them, but they are actually doing it. So they might be, they probably are absolute champions in that area, but we're not. So the champions are in different places on top of different things.
Do you think that in the future you will have common quality indicators to assess the quality in the hospitals? Is that something you aspire to do? Like in a lot of countries, they're talking about quality indicators and quality assessments, that is, well, ranking hospitals, etc. Is that something you've been thinking about, or is it just, well, not necessary and you just go on with your bottom up and working together to improve patient safety?
Actually, the Estonian Health Insurance Fund measures quality indicators, and it does so together with us. So they work with us and talk if their idea is correct and how the data would be best analyzed, etc. The problem with that system is that all the information that they have comes from this e-invoicing. So there are many codes there. There are NCSB codes, and there are, patient information data, and there are ICD codes there, but that's about it. So there are procedures, and so all the information comes from invoicing, basically, not from health records. So there's a question about that, but they have, and it's absolutely publicly available. Anybody who wants can search it, but at the moment they haven't really done anything about it in that way that it would, it doesn't matter what result we get. Which is a two ways way. I don't know if it's good or bad. I don't want to give an answer about that, but yeah, so it is there, but it's not comparing us. I mean, you can see what place you get, but it doesn't result into anything at the moment.
Okay, of course, there's a two-sided story at every porch, so of course you're it's difficult to give one big answer to that, but thank you for giving one short response on that. It's about 5 to 4 in our time. Does anybody want to add a last question? I'll give a 5 seconds opportunity. No. Otherwise, well, thank you all for listening. And thank you, Teel, for your great presentation. As for all the rest, it is recorded, so it will be available online, and you'll be able to re-listen or share it to your colleagues if you want to spread all these good initiatives that have been implemented bottom up in Estonia. So thank you very much, and we'll see you on the next webinar.
Thank you. Bye.